Hello everybody, this is Dr. Potter. We are doing our normal technical difficulties getting Facebook Live started for our hormone discussion. Beth York and I are here. I'm going to let Beth do a lot of talking. My voice is a little off today. My kids shared their virus with me. I'm working on the vitamin C and the biocidin to knock that out, but my voice comes and goes. So Beth York is our advanced nurse practitioner here, does advanced bioidentical hormone therapy. So many of our patients benefit from functional medicine care, but sometimes there are a few little help they need at the end to maintain those benefits with hormone therapy, and sometimes that's really all they need from the beginning, which is why we started our hormone program, where we help patients live healthier, more abundant lives when they just need a little help with hormones and don't necessarily need the full gamut of functional medicine help. So with that, we are going to be doing some case studies to get started, at least one, and then we'll be answering some other questions that some of you have already left, or if you have some questions that you want answered while you're on here live, please leave the questions and comments. Do remember, however, that we are not going to be able to give direct medical advice if you're not our patient. You need to discuss these options with your physician or set up a time to meet with us, and we'll be glad to walk you through that. So, to get started, Beth has a case, and I'm going to turn the video over to her a little bit, and she can tell us.
Okay, so one of the cases that stands out most to me is a patient that was about 41, and she came to me and said that she'd had a total hysterectomy, and her OBGYN had put her on estradiol, had put her on progesterone, and put her on testosterone, all three of those, which would absolutely be appropriate for somebody that was postmenopausal because they'd had a total hysterectomy and had no ovaries or uterus left. But she came to me and we did her levels because her complaints were that she was moody, irritable, and just felt like she was having PMS 24/7. She was tired, she had hot flashes, and was having some night sweats even though she was on hormones. And so when we did her labs, they came back in a way that really was confusing at first, because it essentially showed that she was not postmenopausal, that she was still making estradiol. And what had happened is that she had had technically a total or full hysterectomy, but there had been a little tiny piece of an ovarian fragment left in after the surgery that was still producing estradiol, and it was just hidden because of her endometriosis. So instead of her needing estrogen, testosterone, and progesterone, we took her off of the estradiol, then optimized her progesterone and her testosterone, because even though she'd had this surgery, she still was the same as a perimenopausal woman. You can imagine her surprise when she found out that she was not postmenopausal, but got her settled out pretty quickly. And what was happening was her body was producing estradiol, and then her OBGYN was giving her estradiol as well. And that's what happens when you PMS. So she felt like that 24/7. But she is a great example of why you always want to check an FSH, an LH, and an estradiol all at the same time. Because when estradiol levels are up here, FSH and LH levels are down here. And when you start to lose estradiol, FSH and LH go like this, and it flips. So when you get labs back, you can't automatically say, if you've only done one or the other, you can't automatically say that someone is definitively postmenopausal. So that was one of them. She is happy and healthy now. Another one that comes to mind is a woman that came in and said she had no libido, she was irritable, she was tired, and she had just decided that she just didn't like her husband. And what was interesting is she said her husband had kind of decided that's the same thing, that he just decided he didn't like his wife anymore, he wasn't attracted to her. And it really was a simple case of they both lost hormones and they needed to be restored to the healthiest level. So she needed progesterone and testosterone, and he just needed testosterone. Got things restored, and they realized that really it was a hormonal issue and not necessarily a marriage or relationship issue. So that was a great outcome on that one. And then, let's see, another type of patient that I've seen a good number of here at Sanctuaries. We have patients come in with mold toxicity. And Dr. Potter can speak more to mold's effects on hormones, but it will absolutely wipe out free testosterone. And without free testosterone, you really don't have a metabolism. You have no libido. You're exhausted. You're grumpy. You can't remember anything. You don't have motivation. And you get belly fat, weight gain. And so it's been interesting to go in and sort of partner with Dr. Potter and with Hans here to work with the mold patients, because instead of coming in and having to go through detox and feeling so much worse, we can prevent some of the symptoms and help with their fatigue and help with their sleep and energy and focus and memory. So that's been an interesting thing to do here. So.
Yep. So I will interject a little bit there as far as the her mentioning of mold toxicity causing hormonal imbalance. It does that in a few different ways, and we walk through this, explaining this to our patients. But first of all, not everybody with mold toxicity do have hormone imbalances. Sometimes the hormones are less affected, or the end products, the estrogen, progesterone, testosterone, cortisol, are not that affected, where some of the upstream are. But when they are affected, we will often see both the potential for cortisol being high or low, especially if the ACTH from the brain throws off the production of it. So patients will have the adrenal fatigue is the common term known for that. Also, your aromatase will be upregulated, so you'll, as Beth just mentioned, the fact that testosterone will be really low is for women who start out with a lower level of testosterone in the first place. It will take your testosterone, turn it into estrogen, and they'll end up with some estrogen dominant symptoms, as Beth has been discussing, and loss of muscle mass, loss of libido from the low testosterone. Also happens in guys, but guys start with a higher level, so they don't quite get as severe, and it's one of the reasons why I think men often are a little less affected by mold toxicity. But it is between the cortisol being thrown off, the aromatase being upregulated, and then just the fact that the overall production of hormones often drops, we have to do a lot of rebalancing. And that's rebalancing at the beginning of therapy. As they detox and their body starts working a little better, we rebalance. And at the end, when we've got the mold toxins out, then we are doing a little more handing off to Beth, where she keeps them going along. Sometimes patients go back to normal and don't need that much help. Other times they do need some, especially again women, especially if they're into the menopausal age, some transition into just what we would normally do for a lot of other non-mold toxic patients. So with that, I want to take a chance to ask a couple of questions. Start with a very simple one for Beth. Gail from Townsend asked was just about why the shelf life is so short on testosterone cream. I'm assuming she's talking about compounded cream versus what you can buy at a regular pharmacy as far as injectable or the gels and so forth. So I'll let Beth talk to us a little bit about just the different forms testosterone can come in, and particularly answer why the testosterone cream may have a shorter shelf life than the pharmaceutical versions at a CVS or Walgreens.
Okay, so I will address the shelf life question first about the testosterone cream. First of all, it really depends on the compounding pharmacy you use as to how long the shelf life is. Talked to one compounding pharmacy just the other day, and they said generally there's a 6-month shelf life where they recommend that it's good for 6 months, and they'll dispense a 6-month supply at one time. Most are about 90 days, and a lot of it has to do with the lack of preservatives and stabilizers in it because it's bioidentical. Most people with in the functional medicine world and the bioidentical hormone world want as few preservatives and stabilizers and chemicals as they can get. So I have, interestingly enough, had patients that, particularly male patients, on occasion, they maybe not more than 5% of them, but if they're using a testosterone cream that is supposed to be good for 90 days, toward about day 70 or 75, they start to feel like the testosterone cream is not as effective as it was when they first opened it and started using it. So in cases like that, we just take a simple approach and prescribe 60 days at a time, and then do a new one. But maybe 5% have noticed that. So I would prefer to just err on the side of caution and not do more than a 90-day supply at one time. In terms of other forms of testosterone, for women, we can use a lipoderm cream that you put on the upper inner arm. I have one patient that puts it on the top of her feet, another patient that puts it behind her knees, and it seems to absorb okay there. And then there is a vanishing cream, which is sort of a phyto-based cream, and that is a labia-based cream. It's made for a different type of skin, and it absorbs better there. So you just put it on the labia every morning. It's a tiny little squirt of cream, maybe the size of a green pea or so. Those are the two types I use most often in women. In about 20% of women, we can use testosterone capsules. They don't seem to absorb well for the majority of people. You'll get some relief, but it's really hard to get a woman optimized on testosterone capsules. Most of them will need somewhere between 40 and 100 milligrams of testosterone in a capsule form, but because of liver metabolism, you can't go over 100 milligrams. So we can only get most women so far, even up to 100 milligrams, and at that point it's just better to change to one of the creams. I have had several patients that do testosterone injections, several women. Not my favorite type to treat women or men with, actually, if it goes into the muscle, because it can lower the good cholesterol, the HDL. So, and then in terms of men, some men really want the intramuscular injection because they only have to do it once a week and it's convenient. And if their cholesterol levels are okay, then that's all right. But one of the things we do for men that don't want the scrotal cream is to do a little subcutaneous injection. The needle's about that long, and it's a tiny little thing. And they can do an injection to the upper inner thigh every other day, or they can do it into the fat on the back of the arm. But it doesn't go through the muscle, so it doesn't go through the same metabolism as it would if you injected into the muscle. Those are the testosterone. Those are the most common forms of it.
Yeah. So I had a thought I was going to add to what Beth was saying, but then she moved on. So one of the things in functional medicine we're going to think about is not just what therapy someone gets, but how they get it. So one of the things she walked through was the different ways that testosterone can be given to a patient. Oh, and now I remember what it was. So whether it's oral, whether it's topical, whether it's injection, chemicals of any sort, bioidentical or pharmaceutical, how they enter our body is going to determine, affect how we respond to them. So a testosterone that is taken by mouth, as she said, women can take some low dose because they only need a little higher level versus men need several times higher. For men to get enough testosterone, they would have to take a higher dose by mouth, which when you hear about the bodybuilders, the sports players who had liver cancer, or they had the testosterone rages, where they were just anger and rage and their temper flew off the handle, and even ending up in some legal battles with that because they assaulted someone. For men, doing the oral version is always a bad idea. Women, you can get by with it just simply because they don't need quite as much. As she talked about the fact that when you're doing the injections in muscle versus skin, it's going to affect your HDL, the good cholesterol that helps protect the heart, kind of go around and clean up the mess that LDL leaves behind. For those patients, we'll use that sub-Q version when their HDL is a little bit too low and we might drop it. So we're trying to look at all those factors, so it's not just, oh, one number, high or low testosterone, but it's making sure that the right therapy is delivered in the right way, at the right dose to the right patient, and we're also not going to say, oh, well, just come back in 3 years, here's a prescription forever, and keep taking this because you'll feel, as long as you feel great, just keep doing it. No, we are going to monitor those, especially in the beginning steps, is to make sure that we're getting the right dosages. If we are overdosing, one, it can cause side effects. Two, sometimes a higher dose actually loses out on some of the benefit. And then also, obviously, we don't want to underdose as we're trying to help both with symptoms and disease prevention, which is one of the things I want to let Beth talk about next in a moment, is just about some of the ways hormones help with protecting from disease, not just treating symptoms. So with that, one of the things I do want to say is, for those that are joining us now from the first, as I'm lining up the camera again, it's got a little tilted. We are here at Sanctuary Functional Medicine. This is Beth York, our advanced bioidentical hormone specialist at our office. I'm Dr. Eric Potter. We are trying to help patients live healthier, more abundant lives. And if you are not our patient, we do recommend that you take advice here as just education and questions for your own doctor, or make an appointment with us. We have a hormone program. Our website for that program is launching today, SFM, as in the initials of Sanctuary Functional Medicine, hormones. And you can find out more information, some of the things we're talking about here. Also a way to contact us if you're interested in the hormone program. And Stephen or Sam on our staff will get back to you and help you learn more about how we could help you with hormones. But again, I want to let Beth talk a little bit more, 4 or 5 minutes or so. I know you could talk longer about that. There's a lot of information out there. We're always talking about just some of the new studies coming out where hormones, whether it's prevention of heart disease, Alzheimer's, and so forth. But rather than steal all the punchline, I want to let Beth tell us more about what hormones can do to not only make you feel better now, but keep you well in 5, 10, 20 years from now.
One of the things that you do specifically in the hormone world, but also in functional medicine, is you don't just look at the numbers, you don't just look at lab results, and you don't just look at patient symptoms or what they tell you. It's a big combination, and everybody is so very different. So I'm looking at how hormones would affect your cholesterol, your blood pressure, if they would affect your sleep apnea, looking at personality traits too, because some women come in and even though they would be optimized on the testosterone cream, for whatever reason they forget to use it more often, and it's easier for them to take a capsule. So sometimes that's the best thing. Have another patient that is just worried about using hormone cream, even though it's a perivaginal cream. She's concerned about it because she keeps her grandchildren, and even though it wouldn't affect the grandchildren, she's just uncomfortable with it, so she chooses to do the capsule. So there are a lot of different factors we take into consideration when deciding really what the best thing is for you. With men that choose to do the testosterone cream, that goes on the testicles. It goes on the scrotum twice a day. And occasionally I'll have a man that says, I can't do anything twice a day. I can't remember to do anything twice a day. Not a big deal. We go to another form. But it's just such a personalized and nuanced form of medicine. It makes it a great fit for functional medicine. In terms of disease protection, a study recently came out talking about cancer protection and lowering your risk of type 2 diabetes by using vitamin D. And we use vitamin D3 optimally with K2 in it, but we use that a lot of times for mood, for irritability, for anxiety. It can reduce the incidence of panic attacks, or for some people can make it where you don't have panic attacks. We're using it from a disease protection standpoint, and it falls into the hormone world. We use thyroid supplementation in the same way. We want to reduce your risk of heart disease, of Alzheimer's, and of diabetes. And so we're using thyroid supplementation, and it may be that your thyroid labs are all within normal limits. Just because they're within normal limits doesn't certainly mean that they're optimized. And our goal is to optimize you for disease protection. We don't want you adding a diagnosis every 5 years. You get high blood pressure at 50, you get high cholesterol at 55, you might get prediabetes at 60. We don't want to do that. We want to optimize your health. Have a lot of people ask too, well, I feel fine, why should I do hormones? Well, you feel fine, but why do you eat well? You feel fine, but why do you exercise and move? You feel fine, but why do you avoid toxins? Because you're trying to prevent disease and you want to optimize your health. So just because you feel fine doesn't mean that you can't gain more disease protection from doing hormones. One of the most interesting things that's come out lately is about testosterone and estrogen and their effect on osteoporosis. And there are 3 types of bone cells, or osteoclasts, osteoblasts, and osteocytes. And osteoblasts specifically are full of estradiol receptors. And then androgens, which in our world is testosterone, those are found in all three types of bone cells. So, statistically, you lose 4% of your muscle mass. Women in particular lose 4% muscle mass in the first 3 years following menopause. And menopause would be when you've really lost estradiol. For most women, it's when their period stops and it's gone for a year. 4% muscle mass is a lot when you consider that muscle mass has a greater effect on bone density than weight-bearing exercises. So, we're all told to do weight-bearing exercises, to walk and lift weights, and use our own body weight to build bone, which is a great thing, but we need to concentrate equally as strongly on replacing hormones because they are directly linked to your bone density. One of the interesting things that we can see with optimizing estrogen in women, I've not had a male patient that we've needed to do this with yet, but with optimizing women and their estradiol levels, we can actually do a urine test about every 3 to 6 months called an NTX. And it will tell us whether your body is building more bone versus having to wait for 2 years to have a new DEXA scan. So we can get some reversal of osteoporosis and osteopenia just with hormones, specifically estrogen and testosterone. So that's pretty gratifying to see, when a woman comes in and is really frail and frustrated with osteoporosis, because the studies are pretty clear on the bisphosphonate. And something interesting that happened recently is the American College of Rheumatology came out and said, hey, we know we've been telling you to take the bisphosphonates, which are like Fosamax, Actonel, Beniva, and Reclass. We've been telling you to take those, but by the way, you can get osteonecrosis, which is dying off of jaw bone, and your teeth can fall out. And it's atypical fractures too that are caused by bisphosphonates. And so they came out and said, not only do you need to probably take a sabbatical from the bisphosphonates, but let's look at other forms of therapy. That may be as close as they come to recommending hormone therapy, sort of in the traditional world. But we know we can not only prevent, but we can reverse some osteoporosis and osteopenia with hormone supplementation. So instead of having your teeth fall out and you get atypical fractures of your thigh bone, let's look at hormones.
Yeah. So let's take another question. Is one of the things that comes up a lot, and we also have some discussion about, is what's the best way to test hormones? What's the most accurate way? So I'm going to take a moment to throw a couple of things out there, and then I'm going to let Beth answer that. What we're discussing is whether or not urine, saliva, or potentially blood test are the best way to check hormones. In different situations, each of those have some benefits, but they also each have some limitations. One of it just simply is usually the urine and the saliva tests are not often covered by insurance, whereas the blood test, the serum test, are. So sometimes that makes a difference. There are some forms of the hormone test that can't be done in serum. Some of those are looking at the urinary breakdown products of how someone is processing the hormones, looking to see if they are making hormone metabolic products that could increase cancer risk. So looking at their 2:4:16 ratio of their estrogen, hydroxyestrogens. So with that, we are going to use those at different times. For the most part, when you're treating hormones, most people, some will still use the urine or the saliva, but for the most part, there's a greater consensus that the serum are better levels. So I'm going to let Beth take it from there as far as explaining how those things work. I've kind of got her started probably a third of the way, and then I'll let her finish it up.
Well, we use all three. Mostly we use serum because I'm dealing with patients that are on hormone replacement therapy, on bioidentical hormones. The only thing in my hormone adjustment kind of world, for progesterone, the only thing on saliva that is an accurate kind of predictor is progesterone, and it has to be baseline. For whatever reason, some of that doesn't pick up the metabolites, and other tests do. So I will always measure with blood. Dr. Potter looks also at sort of which metabolic pathway things are going down, and those you can use other methods for. It also depends on what method you're using. For whatever reason, if you use transdermal or cream form, something applied to your skin of progesterone, that will show up more readily on urine and saliva than it will on serum. But only 20 to 30% of women absorb enough progesterone through their skin to justify using it that way. And the topical preparations of progesterone don't help you get to sleep at all. And I would say 98% of women have trouble with insomnia when they lose hormones. So that's one of the things that we use it pretty consistently for. Progesterone is, it's sort of a magic bullet of sorts. It's a precursor to cortisol, testosterone, estradiol. Sleep enhances action of the thyroid hormone, increases metabolism, can provoke weight loss in some women. It can balance blood glucose. It's a natural diuretic, but it is fantastic for helping you fall asleep, stay asleep, lowering anxiety. It really, really can help a lot of women with cyclic or menstrual headaches, the menstrual migraines. It can wipe those out altogether, or it will reduce the incidence and the severity of them. It's hugely protective, though. It's a lot of protection from heart disease, from breast cancer. It prevents breast cells from proliferating, and anytime cells proliferate, you can get cancer. So it helps with that, and it helps prevent uterine cells from proliferating too. So it lowers your risk hugely of uterine cancer, breast cancer, osteoporosis, Alzheimer's, and heart disease. I think for the majority of women, if they had to give up one hormone, it would not be progesterone.
No.
It's that calming and that soothing. So.
Yeah, so I'll add a couple of things. Again, as we talked about earlier, was how, not just which hormone or which therapy, but how it's delivered. Beth talked about oral progesterone will have a greater effect on helping with sleep. Doing the topical, a lot of women, when they're just having mild deficiencies, they do a lot of self-treatment, and it helps some. It's not that they are completely useless, but more when patients get to us, their deficiencies, they've tried that, it didn't work. And sometimes they'll say, I've already tried progesterone. Well, which type? Oh, we tried the topical. Let's try the oral. When it goes through the GI system and is processed by the liver, it actually produces a metabolite that is a GABA receptor stimulator. So gamma-aminobutyric acid, is a nutrient, amino acid, that we will recommend a lot to patients to help sleep or calm some anxiety. So progesterone can actually mimic those effects and help people. That's why it has that benefit when you're taking it in a higher dose through the mouth, through the liver, helping women sleep at night. The other thing I want to do is tie back into how all the hormones interact, in the fact that when we're talking about testing, when we're treating, we use a lot more of the serum, or if we're concerned about cancer risk, we'll do at least once with a urine test to see the metabolites. When we're looking at cortisol, that's something completely different. Yes, we could do a serum blood test for cortisol, but it's going to be higher in the morning and go down in the evening to be low at night and come up. So every day, circadian rhythm, it's going up and down. If we draw your cortisol level at 8:30 in the morning and then again at 12, it's going to be different. So it's dependent on timing. Also, then, we want to know what your function is all day. If somebody says, well, I feel fine in the morning, but I'm tired in the evening, we usually do a saliva test. That saliva test does a sample before breakfast, before lunch, before dinner, and before bed. So we are seeing what the true cortisol curve for the day is. And you say, well, why don't you just do that blood test? Well, number one, most labs are not open at 9 or 10 or 11 o'clock at night when patients are going to bed. And if you're like me, knowing that you're going to have your blood drawn 4 times in a day to check a cortisol level, I might have a little stress and my cortisol might go up. So we will do that with a saliva test. And that's a great simple way that we find out about the cortisol. And then again, I mentioned that it's all fitting in together. So we will try to work through the adrenal glands, down through the thyroid, and then into the reproductive hormones, the progesterone, testosterone, DHEA. What we're trying to do is, if you're balancing the adrenals first, getting that to function, especially if someone's hyper cortisol, too much, overstressed. It's going to inhibit your thyroid hormone production, your conversion to T3. When your cortisol is off, it is also going to have an effect on your ability to make progesterone and estrogen. And if your thyroid, hypothyroid, a lot of women have irregular cycles, not because their ovaries are not functioning, it's because their thyroid is under-functioning. You fix that, and their cycles kind of fall back in place. So we are going to look at the full spectrum of someone's hormones, and then also, especially if you're going through the full program, we will be looking at even how all your body systems around your hormones are affecting you, whether it's your gut health, inflammation, infections, toxicities. All these things interact to make our hormones work for us or against us. So again, we could go just on that topic probably for a few hours about all the different ways that our body is fit in together. But I'm going to, instead of doing that, I'm going to let Beth answer a question. We talked about a lot of things that hormones can help with. A patient, Carolyn, asked about, is hormone therapy helpful for arthritis?
Absolutely, it can be. When you optimize your hormones, you get an anti-inflammatory effect, for one. Now, it's going to depend on if it's osteoarthritis or if it is rheumatoid arthritis. But testosterone and estradiol, testosterone specifically, lowers visceral fat and it lowers subcutaneous fat. Visceral fat is the fat that covers your organs internally and raises your risk of disease. Subcutaneous fat is the fat that none of us like, around the midsection, the extra fat that you want to lose. Testosterone specifically will lower both types of fat, and so it's not as much stress on your joints. One of the common complaints that I get from women that are postmenopausal that have lost estradiol is joint pain and joint aches. And instead of just throwing an anti-inflammatory or an NSAID at it, we would rather get to the root cause of it. And a lot of times that cause is loss of estradiol. Women just get very, very achy. So, and sleep is restorative as well in dealing with any kind of condition. And lack of sleep can raise your inflammation. So progesterone would help with that. So you're getting help from testosterone, estradiol, and progesterone. If you don't yet need estradiol, you'd still receive the benefit, though, from progesterone and testosterone.
So I think, thank you for that answer. I think Beth's going to want me to answer this next question.
Yes.
Can you discuss Snips in relation to hormones? From Angela. Thank you for that question. So, yes, and it kind of gets back to the urine test we talked about, is how someone is metabolizing their estrogen. When we make hormones, it's not just we make it and it builds up and it stores and we just kind of make it. When we need more, we make more, but we're constantly creating hormones and constantly breaking them down. So it's kind of more of a conveyor belt, and the levels fluctuate. That's why we can see throughout a woman's cycle of the month that the progesterone and estrogen levels are going up and down, as our body's constantly turning those over. In terms of the genetics, MTHFR and COMT are two SNPs that play a role in that. With that, before I go further, I do have the comment, was a SNP. This is not something you get at the hairstylist, just snipping some hair off, but this is a single letter change in your DNA code that controls the production of enzymes, proteins, in your body. So our DNA is coded with letters, 4 different letters. With that, depending on what that code is, we'll produce different proteins. Those proteins serve as our structure, as our enzymes, make up all the proteins of our body. When a SNP means that the normal letter that's in that place that codes a protein made in a certain way with a certain set of amino acids is changed. MTHFR, methylene tetrahydrofolate reductase, or COMT, catechol-O-methyltransferase. All those are describing a specific chemical reaction carried out by a protein enzyme. The SNP refers to the fact that a letter change in the DNA caused a amino acid, usually single letter change, in that protein structure. Now, sometimes it may make absolutely no difference, and there's many SNPs that change nothing. either don't even change amino acid, or even if they do, it's so minor a change that it has no effect. In terms of MTHFR, 677, which is just letter number 677 in the series, or 1298, which is letter 1298 in the series of that code, those can change how fast that enzyme works, so it slows it down. For COMT, it's 158 or 62 or 199. There are specific SNPs that will make it change quite a bit. When you are trying to metabolize estrogen, it breaks down as a hydroxyl group, just an oxygen and a hydrogen. Turns it down a little bit, but that 2-hydroxy, if they put it on the 2-carbon of the structure, still has a little activity, but it's a good one. Now, if you make 4-hydroxy, just putting that hydroxyl group on a different place, that estrogen can actually have some cancer-causing effects. So you want the COMT enzyme to take methyl group from SAMe, which is produced by the methylation cycle. So again, how all these things are connected. I don't have a graph up, I could show this to you, but COMT takes a methyl group, sticks it on that hydroxy, turns it into a methoxy, and turns it off. So it completely activates it, so it's not going to be forming what's called a quinone, damaging DNA. Now, one of the things, you have THFR functioning well to make SAMe methyl groups, which then provide methyl groups for COMT to work on the estrogen. So it is a process, and doing that urine test I talked about, there's a couple of companies we used based on whether someone has insurance or not that will cover it, is looking at how fast your COMT enzyme is working. If we need to boost your methylation cycle, that your estrogens are not only too high, but they're processing down the 4-hydroxy pathway. Also, we want to make sure not too much is going down the 16-hydroxy pathway, because that can also slightly raise cancer, but too little of the 16-hydroxy actually puts you at risk for osteoporosis. So we will use that in a lot of our postmenopausal patients at least once to determine, especially if we're going to give them estrogen, to see whether or not they're imbalanced. Now, don't necessarily need to do that in everyone. If someone doesn't have a family history of cancer and there's no other signs that that's an issue, we will just start using the serum test. But those are some of the ways that we look at Snips in terms of how they process. There's a whole lot more genetics I could go into, but probably without having a board or a graph to show you, it would be easy to get lost in the weeds of that. So hopefully that answers the question well. But we, if you have other questions to make sense of that, you can always still leave it on the our Facebook page later or the website, and we can answer your questions as best we can. So I'm going to take a pause for a second and just remind everyone that this is Sanctuary Functional Medicine. I'm Dr. Potter. Beth York. Beth York is our advanced bioidentical hormone specialist here. We are discussing how hormones can help your health. We have been doing our new hormone program, but we've got our website up and running, SFM Hormones. Can tell you more about our program, and we're looking forward to hearing people through our contact page there, asking questions. But I'm going to take a pause for a second, and Beth, if you would give us another short case that we're helped a particular patient with hormone balance by doing some bioidentical hormones.
I've actually, this would be a combination of multiple patients. Often have women come in usually mid to late 30s or through their 40s and in their 50s, and they have a new diagnosis of ADD or ADHD. I would talk to them and say, did you have trouble in childhood? Did you experience trouble in early life with focus and concentration? And they would say, no, this just all started in the last 2 or 3 years. I was put on something for anxiety, then I was put on something for depression, and now they want to give me something for ADD, ADHD. Generally, if symptoms didn't start in childhood, then odds are good that it's not ADHD or ADD, and you need to look at your hormones, because it can make you very flighty, can't remember anything, you're tired, you lack motivation completely, You walk into the kitchen to do something and you get there and you forget why you ever came in there. So it's really gratifying to be able to talk to women and explore a little deeper what their history is, and eventually get them off of the medications for depression, for anxiety. Getting patients off of sleep medications is an everyday occurrence in the hormone world. And getting them off of ADHD medications is also a great thing. Less chemicals, the better.
Yes.
If they're not giving you any disease protection. So.
Yes. So I'm going to do another question that was sent in. I'm going to read this. Beth has not heard the question yet, so throw up the pitch and let her swing at it and hit it out of the ballpark.
Awesome.
Had a hysterectomy at 25, now 45. In the last month or so, started experiencing what I'm thinking are hot flashes, extreme irritability, excessive sweating, never had before, and fatigue. Always assumed I went into menopause after the hysterectomy 20 years ago. I'm thinking I may be experiencing it now. If so, what do I need to do to stop or control this? And this is from Diane. So thank you, Diane. So if you want me to repeat any of that, that was a long question, but I will hand it off to you for that.
Hey Diane, pretty common question that we get. One, we would need to know whether it was a total hysterectomy or whether it was a partial hysterectomy. Some women just have the uterus removed but keep their ovaries. Some have the uterus and one ovary removed, and then a total hysterectomy would be to have both ovaries removed and the uterus. It sounds to me that if your symptoms didn't start, and this is a guess, educated, experienced guess without talking to you in person and getting more details, but it sounds to me that if you didn't have symptoms immediately following your hysterectomy, which would have been surgical menopause, and you're just experiencing them now at 45, sounds like you probably have your ovaries and they're just starting to peter out, which is a normal thing to happen between about the ages of 38 and 48 or so. Fatigue, irritability, moodiness, memory loss, lack of motivation, decreased libido, increased belly fat, weight gain, muscle mass loss, those are all really, really common signs, symptoms of testosterone loss. And night sweats. You tend to get night sweats associated with testosterone loss. The next hormone to go, and it sounds like you've kind of hit that stage 2, which is normal, would be progesterone loss. And with progesterone loss, you'll have trouble falling asleep, you'll have trouble staying asleep, you'll have more irritability and moodiness, you'll cry at silly commercials and stupid movies, cry for no reason whatsoever. You may be getting more headaches. If you still had a uterus, your bleeding would probably be heavier. And you can get hot flashes in response to, and hot flashes and night sweats, the difference is just when they happen. Hot flashes tend to be more common during the day and associated with estrogen and progesterone loss, whereas the testosterone loss is more associated with night sweats, at night. So what it sounds like to me is that, and with your excessive sweating, it sounds like you've lost testosterone and progesterone for sure, or lost enough of them to make you really symptomatic. We would need to do hormone levels, get blood work on you to look at something called an FSH and an LH. And when we look at those, we want to see that FSH and LH is way up here and estradiol is way down here to know if you're postmenopausal or not. A litmus test that I often will talk about with women when they think they've gone through menopause, total menopause, and they haven't. Usually, and this is true in 95-98% of the time, if you don't have daily vaginal dryness, when you think you've gone through menopause, then you probably have not gone through menopause and you're still making enough estrogen. Now, there are exceptions to that. If you're 30-40 pounds more overweight, you can have less vaginal dryness because of estrogen metabolism. So, but I would get hormones done. Wherever you decide to have hormones done, please make sure that they do an FSH, an LH, and an estradiol specifically, so that you can know whether you are postmenopausal or you're perimenopausal. And perimenopause is the 10 or so years prior to total menopause, when you've lost testosterone, progesterone, and then finally estrogen or estradiol. So your symptoms are pretty easy to fix, though. I'll tell you, it's not complicated. It's an everyday occurrence in the hormone world. And we want to return your hormones to where they were between the ages of 25 and 30, and not just leave you normal for your age, because it sounds like you are normal for your age, but we want you optimized. So
We're going to take another question that I'm seeing up on our Facebook page from Brenda. What are the symptoms if you're getting too much estrogen, too much testosterone, too much progesterone, and also which estrogens? There's estradiol, estriol, estrone. So let's take that too much question first, and then we'll answer kind of the different types of estrogens as well.
Okay, so I'm hesitant to say that it's a sign of getting too much. If you start with estradiol specifically, now estriol, the two types that we deal with in hormone replacement in bioidentical worlds are estriol and estradiol. Estradiol is the one that gives you tons of disease protection and symptom relief. Estriol can help with vaginal dryness, but that is it. It doesn't give you disease protection. So I typically only work with estradiol unless somebody asks me to put estriol in there, and then we certainly will, but estradiol will fix vaginal dryness 100 times better than estriol. So with the estradiol, if you've been without estrogen for a while and we start you on the dose that I know you're going to need to be optimized or close, odds are good that you're going to have some fluid retention, some breast tenderness related to fluid retention, kind of how you would feel at the beginning of pregnancy. And so I don't start you on the dose that I know that I think you're going to need to be optimized. I start you on the dose that will give you symptom relief but won't cause symptoms of too much estrogen too quickly. And so I don't want you to have the fluid retention. It's just uncomfortable. It can cause breast tenderness and have to change bra sizes and all of that. So in terms of getting too much estrogen, you could, if it truly is too much, then you could have hot flashes and PMS. But the range is pretty wide for where you want to be optimized. At a standard labs that we use, you want to be at 75 or higher. Some women feel best at 125. Some women feel best, honestly, at 65. But I would say on average about 80 to 100 is where they feel the best. That's for the estrogen. Testosterone, you can have symptoms of too much. Women are very different from men. Men, I can give testosterone to, and I can bring their levels up to 50% of where they need to be optimized, or I can give them, I wouldn't, but I could make them 2,000% optimized, and they still feel great either way. It doesn't affect them. Women are more a bell curve, and it's a much more narrow range. So when you don't have enough testosterone, I can put you on testosterone, and if it brings your level up to here, you feel good. If it does this, then you feel good. But as you start to get on the higher end of the range, you can start to lose the benefits of symptom relief, and you can start to feel like you don't have enough testosterone. And in women, the most common thing that we see if their testosterone levels get too high, which is pretty unusual, but the most common thing we see is maybe increased acne right here. Have one patient who doesn't, a male patient that doesn't love his testosterone levels to be optimized because he gets scalp acne, but that's one out of maybe 2,000 that I've treated. You can also get a little bit more chin hair growth. You're not going to grow a beard. If you didn't have chest hair and a beard for women when you were 25 to 30, then what we do with bioidentical hormones is not going to give it to you now. And you have to push the levels pretty high, but you just have to watch it more narrowly, I guess, for women than you do for men. In terms of progesterone, you can't overdose on progesterone. It's a ton of disease protection. But I will say 1 to 2% maybe of patients, of women, men do not take progesterone, by the way, it's only women. 1 to 2% of women will notice a little bit of bloating, abdominal bloating, their stomach will bloat out. And I have seen one patient do this ever in the thousands that I've treated. But she actually got more depressed and more anxious and couldn't sleep. And she's just in that tiny little minority. But for the most part, if you took too much progesterone, the only thing it's going to cause is maybe a little bit of breast tenderness, which you can fix with vitamin E for 3 or 4 days and it's gone for good. Or you might be a little too sleepy the next morning. It's a matter of adjusting the dose, but you can't overdose on progesterone.
So let's try to get one more question in here. Jane asked, how quickly can a woman feel better once hormones are dialed in and she's able to lose the weight gain?
Alright, so How quickly? If you need estradiol, then within a week of starting estradiol, you'll typically feel some symptom relief. You'll get relief from hot flashes within 2 to 3 days usually, but we'll say a week to be on the conservative side. You will get relief from vaginal dryness within the first week, and you can get relief from joint pain within the first week. Even though we want your level to 75 or higher, you should get symptom relief when we get your levels up to about 32 or 33. That seems to be the sort of breaking point for women. For testosterone, it takes a little longer. It takes about 2 weeks for you to notice sort of an uptick in your energy and mood. And then libido takes about 3 to 4 weeks in general. 6 weeks we say you're going to be optimized in terms of you're going to be at the best level that you're going to get to on that current dose. It's not unusual for us to start you on something and just get your level up to get you 50 or 60% better and then go from there. I would rather do it that way in a slightly slower increase than start you on the doses we think you'll need and you'll have side effects from it just because your body's not used to it. So in terms of the weight gain, that's a little trickier question because it's so multifactorial. And I would never promise anybody that if they took hormones, bioidentical hormones or otherwise, that they would lose weight. However, it is kind of restoring your metabolism to where it would be when you were younger. It's also allowing you to build and maintain muscle mass because you're taking the testosterone. And your lean muscle mass is a huge part of your metabolism. So some women, I would say 5 to 10% don't lose any weight when they start hormones. I would say anywhere from 70 to 80% are able to lose some weight and firm up, especially as long as they have a clean diet and they're moving and exercising. And then I would say 10% or so kind of stay where they are. So it's a very individual thing, but I have never seen anyone gain weight really as a result. They may gain some temporary water weight, but that tends to go away over the course of first 2 months or so.
So I'm going to wrap it up with one more question from Brenda that is actually a good good way to bring this to a close because it comes back to what we talked about at the beginning, that hormones are not the only part of our health. They are just one of the factors we look at from a functional medicine approach. But Brenda also asked, are there other things that can be done to lose weight while rapidly dialing in the hormones? No, not Brenda, that's Jane. Sorry about that. With that is we are going to look at, are there toxins that are causing your metabolism to derail and store instead of burn fat? We are going to look at deficiencies. You need things like carnitine to burn fatty acids in the mitochondria. And if you don't have enough of that, especially in vegetarians, that can be a problem. We are going to look at infections. Chronic inflammation can cause you to hold on to excess fat. We are going to, other toxicities, mold toxicity could be an issue. So gut dysbiosis, you may have heard some of the studies where taking a mouse which is overweight, taking the bacteria out of their colon and putting it into a skinny mouse can actually make that skinny mouse turn into an obese mouse. So there are issues in our guts that are affecting that. So it's hormones, it's infections, it's toxins, it's vitamin deficiencies, gut health. It is a lot of different things, and as tied in finally with what Beth said, clean diet, doing exertional things where you're burning calories, but for those who feel like they are burning calories and not getting anywhere, we look for those obstacles, deficiencies and toxicities, too much and too little of things. So again, we thank you for joining us. This has been Sanctuary Functional Medicine with Dr. Potter and Beth York. We've been talking about hormones because hormones is what Beth specializes in with advanced bioidentical hormones. And helping patients live healthier, more abundant lives is what we do our best to work at. With that, check out our new SFM hormone site on the web, and we'll help you learn a little bit more about our program we offer, ways hormones might help you, and if you have other questions that you leave on the Facebook, we may be able to get back to them over the next few days. So phone number, I think Stephen has left our phone number there. If you want to give him or Sam a call, they can tell you more in person, or again, you can send a contact form on the web. So look forward to talking with you again. Until then, have a blessed day and live a healthy, more abundant life.